evening all to the 114th session of the Weekly Huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We both are cardiologists working at KIMS Hospital, Secunderabad. As you all know, that the Huddle is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily practice. Today, I bring to you one similar clinical case which I recently saw in my cardiology OPD. While these cases are not that common, we do see it once a while, and I think it is relevant for practitioners like cardiologists and other specialists who have lost a little bit of touch from their pure internal medicine to kind of revise the topics and also guide the patient towards appropriate specialties. Now, we're starting with a thin audience, so I will ask each one of the attendees to share their thought once I get Praneeth's opinion onto this. And to facilitate in our today's discussion, I am joined with Dr. Sharath. He is a practicing gastroenterologist and hepatologist at KIMS Hospital. He will be helping us with our discussion as well. So, having said that, I will get started with the case, the details of which has already been posted on the WhatsApp Huddle group. I will read it out for each one of you. And then I will start with asking my colleague Praneeth for his opinion. And then I will take opinion from others as well. So this is a 56-year-old female. She actually is a wife of one of the patients I recently treated. And I kind of saw her as like, doctor, you're seeing me, might well just see my wife as well. She didn't have any active complaints for me. She just kind of one for one free kind of thing. She's 56-year-old female. She's hypertensive for about 4 or 5 years now, which is reasonably controlled, it seems, on telmisartan 20 milligrams twice daily, once daily, which she has been taking for about 5 years now. She, 6 months back, complained of retrosternal chest discomfort, which was not typical of angina. This was evaluated by an outside cardiologist with the routine assessment that included ECG, echocardiogram, and a treadmill test. This combination of investigation was actually done twice on him, twice on her in the past 1 year. Both of the times it was reported to be normal. At that time, she did bring it to her cardiologist that she has noticed about 4 to 5 kilograms of weight loss. And at that time, she was advised to go and meet a gastroenterologist, which she did not do. She didn't have any other complaints to report at that time. Now, in the current visit, which is 6 months from the first visit that I told you, she again denies any particular complaint. She does not have any fever. She does not have any any overt weakness of sorts, and no any rashes or anything. She has not noticed any nausea, vomiting. Her appetite is slightly low. She feels a little bit of anorexic, but that she doesn't think is out of ordinary. Her family always considers her as somebody who doesn't eat much. Her baseline weight is around 50 kilograms, and in visit to my OPD, her weight was 40 kilograms, making it a 10 kilogram drop in her weight over approximately 1 year. And she is not trying to lose her weight. She's trying to maintain her weight as much as she can. As I said, that she didn't have any particular symptoms to report. She just came to show her husband, and in doing so, she showed it to me as well. She's non-vegetarian, but she consumes non-vegetarian food very sporadically, probably once or twice a month or so. Otherwise, she eats whatever comes on her way. As I said, she doesn't eat much to begin with. On her examination, she's a thin-built lady. I could not elicit any localizing signs whatsoever to what I could examine and what I could get. She came with routine lab investigation, which included hemoglobin, renal parameters, TSH, and HbA1c. She didn't bring liver parameters with her, which I ordered, and all of them came normal. I did not order any cardiac evaluation because her ECG and echocardiogram done previously was normal. So the way I concluded this case was that she is a middle-aged lady with hypertension who now has about 10 kilograms of unintentional weight loss, going from 50 kilograms to 40 kilograms. And To the best of my clinical capacity, I could not elicit any localizing signs in her. Her retroesternal or epigastric discomfort to me looked like dyspepsia, for which I prescribed her antacids. Other than that, I didn't do anything else as far as treatment modalities are concerned. So we are going to discuss today how to evaluate these cases with weight loss who do not have any obvious localization. And I have certain points which I would like the discussion to focus on. Those points are: number one, when to trigger alarm for evaluation, like at how much kgs are enough for you to trigger an alarm for weight loss. Is it based upon kilograms or pounds, or is it based upon percentage body mass loss? Is there a way, is there an algorithm that we all follow? Second, we all are thinking about occult malignancy in her case, but other than that, what else are we thinking of? Is GI a malabsorption one of the differential? Should we be thinking of tuberculosis or anything else in that regard? Obviously, for a cardiologist, we are always looking at cardiac cachexia, which this patient definitely did not have any cardiac ailment to qualify for cardiac cachexia, so that I did not put it as a differential. Third will be, what will be the first order of investigations? I'm sure there are a ton of investigations which can be done to evaluate for why this weight loss is happening. But what I want to discuss is what would be the first order of investigation? Like, what will be the first set of orders that you will write in the prescription sheet? And based upon that, you will take further actions. Now, assuming the patient came to me as a cardiologist, where you will guide me to send this patient to? Now, a comprehensive medicine assessment will probably be the ideal situation. Barring that, what kind of specialist we should be referring this patient to? Is gastroenterologist enough? Is it a good place to start? Or should we be looking at oncology directly? Should we be looking at any other specialty, what so speak? So these are the discussion points that I want to highlight today. My request to all the attendees is that while we discuss this case, we should focus on the kind of presentation that I am describing here, where we have a patient with no symptoms. I'm sure we can go through the route of what if this patient has this symptom, then we can do that. For all purposes, I request you to assume that I could not elicit any overt symptoms. So assuming that whatever she's reporting, that is all is there. So with this background, I will ask Praneet to give his initial impression, what you would do when this patient comes to you. And then we will ask I'll ask other attendees to share their opinion. And then we will go to Dr. Sharad for his thoughts. So Praneet, all yours.
Yeah, good evening, everyone. So this patient who was detected to be having incidentally reduced weight, patient does not actually appreciate the loss of weight, and she does not have any constitutional symptoms. Most of the time, whenever there are no constitutional symptoms, there is reduced appetite, but it is not significant. But for the sake of discussion, when there are no other constitutional symptoms, most of the time having some underlying abnormality, in my opinion, is less likely. What I would consider for this patient is probably her overall intake of food is probably reduced, which has contributed to her weight loss. The other possibility that I think of is there may be an associated depression or any mental health issues where you are again probably contributing to reduced food intake and overall not taking care of yourself, probably contributing to the so-called malnourished state and loss of weight. These were the thoughts that come to my mind firstly. But these are some things which normally come as a diagnosis of exclusion. Do not want to roll out, do not want to miss out anything organic. When we go further, probably again malabsorption syndrome, the commonest, probably in my opinion, maybe parasitic infestations could be one possibility which are contributing to her malabsorption or malnutrition. And then Probably some GI issues. Obviously, the last thing that comes to mind is oncology. Some occult malignancy sitting inside, which is contributing to her loss of weight and loss of appetite. That is the last thing that comes into my mind. When what investigations I will do for her to begin with, probably from history. Again, we can look into it, but these are some things. Again, I'm not a psychiatrist per se, but probably at least I'll kind of poke into her personal history to look into whether there is any element of depression. And in general, if time permits, I will ask her about what is her food diary or something, how much is she consuming, to understand whether she is in general consuming lesser quantities of food contribute to her reduced weight. Investigations, I'll start with basic investigation, which you already have done. Some things which I may look into is probably chest x-ray, both API and lateral, maybe to find out any mass or anything to explain, particularly to look into some tuberculosis or malignancy, any masses which can contribute. An ultrasound abdomen and pelvis to look for again organ assessment and any issues. And probably would ask her to encourage diet and other things. Because again, I'm not a concerned specialist. If her symptoms continue, I would firstly refer her to a medical gastroenterologist, because I believe again it is related to her intake of food and other things. So I would ask a gastroenterology opinion, probably expecting an upper and lower GI endoscopy to look for any mass or lesions, because again age is something which may not be the absolute criteria not to consider malignancy, because we are seeing people also having uh, malignancies at younger age group. Again, because she is a lady, if the order of malignancy, if we consider the commonest thing, probably a gynecological examination to look for any gynecological malignancy, and second thing, a thorough breast examination also to look for any mass which can contribute to malignancies. So unless a diagnosis is not being confirmed, so referring to a medical oncologist doesn't make any sense. So we probably should make a diagnosis then refer. So as a physician, first you find out whether there is any issue, and if there is no organic issue found out, and if the suspicion of malignancy is there, maybe clues in relation to elevated ESR or C-reactive proteins or any other things, then maybe ordering for imaging in the form of contrast chest scan from neck, chest, and abdomen, and finally probably a PET CT scan. But I would start with uh, X-ray, ultrasound abdomen, and if these are normal, I would be happy to refer them to consult specialist. But the thought process is what I mentioned earlier. So referring probably to first gastroenterologist, and maybe equally to a gynecologist to look for any other issues. And if diagnosis confirmed, or if there's any mass or anything which can suggest, probably then an oncologist. This is my take on this case, Anu.
So Praneeth, few questions. Number one, you mentioned that you will try few things and see how things go, and then take a decision. This patient is having this so-called weight loss for about a year. Would you still like to try, see how her appetite is and whatnot before referring it, or before escalating the investigations? Or you think 1 year or 10 kilograms is good enough for you to start investigation right away?
I would start investigating the basic labs right away. The special investigations I would reserve. I believe her intake of food is low. So this 1 month, I would suggest her to try to maintain a food diary as to what is she consuming and how much is she consuming, to so as to understand whether her total calorie intake is probably sufficient enough to her basic metabolic needs or something. So for a month, I will be doing these things simultaneously, basic labs and asking to maintain a food diary and trying to pay attention to the intake of food that she is doing. And if these things doesn't fail, then I would refer to a specialist.
And then the last thing I remember, we discussed this in one of the huddles about deworming, empiric deworming. Is there a role for, like, what do you do typically when you have these kind of cases? Anything which can justify doing empiric deworming in these patients?
Yeah, so post that huddle session, now that we understand that albendazole and ivermectin combination seems to be the best strategy, and it is also available in as a single pill for whenever I suspect them to be having any possibility of having any parasitic investigation, be it iron deficiency, anemia, or any abdominal symptoms are suggesting. I would suggest, or I would give them an empirical antiparasitic just in case if it is contributing to anything. So I believe it doesn't harm. So whatever advantage that it can do, it can do. So I don't think we should think much in prescribing empirical antiparasitic agent.
Thank you so much, Praneeth. I will move on. And my reminder to all the attendees, if you do have any questions, comments, or suggestions while we are discussing, you can raise your hand or put your questions or comments on the chat box, and I will bring it up as soon as we have a break between our talks. So, Shankar sir, I will ask your opinion on this. This is exactly your subject. I know that once a while we do bring up a hardcore cardiology topic. This is exactly what your specialty, if I may, would be. This patient comes to you. You have to take my words that I could not elicit any relevant history other than what I mentioned. How would you take it up? Just walk us through your initial thought process in this patient. Shankar sir.
Good evening to all. This is an interesting case. When there is a progressive unintentional, unintended or involuntary weight loss, more than 5% of the body weight, it is considered to be a serious one. Here, she has lost 10 kg in 1 year. Her earlier weight was 50, and within 1 year, she has come down to 40 kg. So 10 kg loss. So it comes to more than 20%, around 20% of body weight loss. So this is a very serious matter. So we should investigate in a detailed manner. So already investigated, the anemia of chronic disease is ruled out. Anemia, there is no anemia because hemoglobin is normal. Chronic kidney disease is ruled out, and chronic liver disease also ruled out because of the liver and renal parameters are normal, and TSH is also normal. So that indicates that the hyperthyroidism, which is a cause for weight loss, is also ruled out. Then HbA1c is normal. The diabetes is also ruled out. These are the conditions we come across in day-to-day practice, the chronic kidney disease, liver disease, hyperthyroidism, then anemia for chronic disease, and the cardiac cachexia also ruled out here. So then looking at this case, more than 20% weight loss. So first, the thing which comes to my mind is anorexia nervosa. That is a psychiatric disorder commonly seen in females, of course in younger, but here she is 56 years old, but it is common even in the middle age also. So any depression disorder, depression also causes some such amount of loss, and any food related delusional disorders. So psychiatric evaluation, psychological evaluation has to be done in this case first. And second is she is addicted to any substance or any medication like cocaine, amphetamines, cannabinoids. Also, we should take a detailed history regarding the substance abuse. Having ruled out these psychiatric disorders and substance abuse, then infections they come to my mind most of the times. HIV, this human immunodeficiency virus infection, most of the patients, they come with marked loss of weight. Then tuberculosis, as Dr. Praneeth mentioned, so pulmonary or extrapulmonary, chest X-ray, sputum examination. If there is symptoms are there, then CBNAT of the sputum, or if she brings out sputum, or if any extrapulmonary tuberculosis where we get a tissue, for example, if a lymph node enlargement is there, that biopsied lymph node can be subjected to CBNAT, and we can find out the tuberculosis gene expert positivity. So pulmonary and extrapulmonary tuberculosis, it has to be kept in mind whenever in India, especially the endemic country for tuberculosis. HIV and hepatitis C. Dr. Sharath is there, he will enlighten. So hepatitis C, now we have got a very good treatment for the almost complete eradication of hepatitis C if once we diagnose it. So most of the times we miss the bus. Hepatitis C, HCV, anti-HCV should be investigated. So these are the common. Others are there, sarcoidosis and others, granulomatous diseases. But to my mind, HIV, tuberculosis, and hepatitis C are the infectious causes for the weight loss. Then endocrine disorder, already hyperthyroidism is mentioned, is ruled out. Then Addison's disease also, they come with weight loss. So if we do plasma cortisol, we can diagnose this Addison's disease, where the patient comes with pigmentation and weight loss and hypotension and all. Then the non-malignant conditions, especially already mentioned, that is a malabsorption, when the patient comes with watery diarrhea or steatorrhea, a pain abdomen, weight loss and all. Then we have to seriously, any nutritional deficiencies, definitely we should think of malabsorption. Then we have to investigate further. And celiac disease is also now it is coming to the limelight, and Dr. Sharath may enlighten also regarding the celiac disease and the malabsorption, and inflammatory bowel disease, IBD. These the non-malignant conditions where the malabsorption, celiac disease, and the inflammatory bowel disease, IBD, they should be kept in mind where the patient comes with marked weight loss. Then ultimately the occult malignancy, this should be kept in mind. It should be, the cancer screening has to be done. If there are no localizing signs, then she's a 56-year-old female, the breast screening with mammography, then cervical cancer with the pap smear or HPV testing, then colorectal cancer with the stool for occult blood. Other investigations are there, like but Dr. Sharath may enlighten, I think, the fecal immunochemical tests measuring the hemoglobin in the stool, then multi-target stool DNA testing. There are advanced tests where we don't get positivity, the FOBT, that is a fecal occult blood test. Then we have to investigate further with the advanced ones. Then endoscopy, the colonoscopy, sigmoidoscopy, the upper GI endoscopy, the colonography, and all these things, the virtual colonoscopy, and all these things which should be done to diagnose the conditions what I mentioned about. So the ultimately the lung cancer also should be kept in mind. If you take chest X-ray, sometimes we may not. Then we have to HRCT, the high resolution computerized tomography chest. So the thoracic abdominal pelvic scans or CT scans. Sometimes they will give a clue for the occult malignancy. And as Dr. Praneeth mentioned, ultimately, suppose in spite of investigating for all these things, they come negative, then we can try for the PET CT. Is there any infection or malignancy localization can be done with that. So last thing, see here, I strongly suspect in this case is only psychiatry, because over 1 year with no constitutional symptoms, so all the investigations they come normal. But before we embark onto the psychiatric disorders, we have to investigate these infectious, endocrine, non-malignant, and the malignant conditions. So after investigating all these things, they all come negative. So in 15 to 20% of the cases, unintentional weight loss cases, there won't be any cause for the weight loss. So we have to waitful watching should be there. So over a period of 1 to 6 months, so any localizing sign may come out. So this is regarding my approach to this case of weight loss. Thank you, one and all.
Shankar sir, I have a lot of questions for you. Number one, you mentioned an overview of a lot of these things which can be done. But at the same time, I hear you when you say that because the symptoms have been there or the weight loss have been there for a year, it is highly unlikely for a cancer to be hiding for a year and not show up in either a constitutional symptom or in any other form. So you also think that it could be psychiatric or it could be behavioral. But you have this patient here with substantial weight loss. At what point would you test her and say that, okay, now I'm going to pause and give you a month or 2 break and ask you to come back again? Would you do everything that you mentioned and then tell her, let us wait for a month or 2? Or would you do few of them and say, okay, now it is enough, let's wait for a month and then come back again to finish the rest if the weight gain doesn't occur? How would you approach, how would you take care of this patient?
As I mentioned, the infectious, endocrine, and non-malignant conditions can be done, and we can find out the cause. But only coming to the only occult malignancy, as you said, over a period of 1 year, they may have some localizing signs. So depending on the appearance of the localizing sign, we can investigate further. Suppose a lymphadenopathy comes out, then we'll investigate for the lymph node for the biopsy. Lymph node biopsy will do. So likewise, the symptoms if the patient passes so bloody stools, then we'll investigate with the colonoscopy and the stool for occult blood. So likewise, when all these investigations they come normal, then waitful watching, that is the only ideal thing. Every month we ask the patients to come for OPD every month, and we'll ask for any localizing signs have come out, and the history and physical examination will do, and necessary investigations will do. We'll find it out any cause for the weight loss. But in this case, definitely I firmly believe that over a period of 1 year, more than 20% loss of weight without any localizing signs. So I firmly believe this is a psychiatric disorder or any substance abuse.
Okay, sir, I'm going to ask you a few more questions. And at the same time, I would ask my attendees, if you have any questions, comments, or suggestions, please either put it on the chat box or you can raise your hand and I'll give you a chance to speak. So, sir, just continuing with your thought regarding physical exam and whatnot, I will tell you what I did and I will ask you if you would do something extra. So I examined her cervical lymph nodes. I did not examine her other lymph nodes. So my question to you is this, in this situation, is it worth going and examining her axillary and femoral lymph nodes, inguinal lymph nodes, and all those, or you think that's an overkill?
No, generalized lymphadenopathy, all the sites should be examined because that gives some localizing sign.
So
Or
you would,
if it is generalized also, certain conditions are there where we can suspect or we can send for the biopsy.
okay. Second question is, again, I did breast examination on her. Her daughter was there. It wasn't that difficult for me, but I didn't do a gynecology examination for obvious reasons. The question is, in the absence of any active gynecology symptoms, would you send her to a gynecologist for a routine examination for weight loss at this point of time?
Routine we don't send, but only if the patient comes with chronic white discharge or any bloody discharge or dyspareunia, some symptoms related to the pelvic organs, then we'll do pelvic scan, ultrasound scan first initially. If it is inconclusive, then we'll go for the pelvic scan, pelvic CT scan. Then if anything comes positive like ovarian cancer or cervical cancer, then we'll refer it to gynecologist. So when the patient comes with white discharge or leukorrhea or bloody discharge, then directly I send it to gynecologist.
Thank you so much, Shankar sir. I will move on.
And regarding the breast,
yes,
we can send it to mammography, even ultrasound breast. We can find out any mass lesion. So even they will do even axillary lymph nodes also. They will search for in the ultrasound or in the mammography. Thank you.
So I did not send her for breast scan because I thought that if it was a cancer leading to this kind of weight loss, then a simple breast examination will pick up if there is any nodule or something. So I did not send her that. I will tell the audience what I did. Other than what we discussed already, I sent this patient to a gastroenterologist to do the first assessment. We do have a gastroenterologist with us, Dr. Sharath. Now, he was not the treating physician for this patient, but I will ask Sharath, sir, sir, what would you do if this patient comes to your OPD from mine, seeking your evaluation for weight loss? You heard the entire story. We are looking for your opinion on this. Sharath, sir. Sharath, sir, we cannot hear you. You are unmuted, but we cannot hear you. Can you please test your mic? Sharath, sir, we are not able to hear you. Okay.
Can you hear me now, Anoop?
Yes, now we can hear you. Please go ahead.
Yeah, so I said, first of all, thank you. And this is a wonderful concept of getting together and having an informal discussion, but it's actually real life stuff, the difficulties that we face on a day-to-day basis. You can hear me, right? Hello?
Yes, we can hear you. Yes, we can hear you.
Yeah. So first of all, I do get this, I do get patients like this on a very regular basis. Being a gastroenterologist, weight loss is probably maybe 1 in 20 patients that I see present with weight loss, roughly speaking. The first thing I would do is I would actually check the weight. I think that's the first thing I start doing. A lot of times I get patients in my OPD that come and report that I'm just not feeling good. I think I'm losing weight. The history tends to be a little vague. I think I'm not eating that well. So the first thing to do is record the weight and establish that they've lost weight. So in this case, because it is so obvious and overt, it's 20% of the body weight. I guess there is definite weight loss. Number one. Now, number two, I think you all quite extensively covered the causes of unintentional weight loss. I would say the devil is in the detail. And a lot of times there are very, very subtle signs. And if we persevere with the history, and if there is good time spent during the consult, I think by the end of the consult, you will have a fair idea why the patient may be losing weight. This is a very difficult problem. And from what you all have summarized, this is just weight loss and we have no pointers. We have no localizing signs. So we have nothing from the history or examination that is giving away a diagnosis. So I'll talk about a few things from my experience. I hope I'm still audible, right?
Yes, sir, you are still audible.
Yeah. So now, a lot of times, I mean, when a patient reports to me that I've lost weight over 1 year, which is a longish period of time, and I've lost 10 kgs, I would want to know if, what is the pattern? Is this like a steady losing 1 kg a month over the last year, for example, or there was a little bit of weight loss during the initial part of the year, and the weight loss has really got worse in the last 2 months, and that precipitates a physician consult, or they lost weight several months ago, and since, for example, first half of the year they've lost 8 or 9 kgs, and they're not able to put the weight back on. Now these scenarios are all slightly different to each other. So, for example, if it is a steady weight loss, or if there's a progressive weight loss, as in recent times, if they've lost more weight, that would concern me. On the contrary, if somebody has lost weight previously and they're not able to put it back on, they still come to the doctor and they will still tell you that they've lost weight. So it is for us to decipher the pattern. Now, for example, somebody has lost weight initially, and for the last few months before they have seen you, it is static. I think it is, for me, that is a little bit more reassuring. For me, it gives me a clue that I need to go back all those months ago, dig into the history, find out exactly what happened. And that requires a lot of patience from the doctor, because a lot of times patients don't remember the temporal sequence of events. And in my experience, some of the things that I have, dug and successfully found out, for example, a COVID illness, we are going through a pandemic. COVID happened 1 year ago. Patients sometimes they won't necessarily make the connection unless you've actually, engaged and brought it up to their cortical level. So COVID happened 1 year ago. It may not have been severe, needing hospitalization or ventilation or HFNC or whatever, in which case they would remember and tell you. It might have been something less than severe, but still, COVID has caused havoc for a lot of patients with their GI tract. So I would find out what happened 1 year ago. How did it start? So it could be COVID, or it could be another viral or a bacterial infection, something like a typhoid, where you need a reset. And you may have gone off food, and and particularly if you are in the second half of your life, this lady is 56. After you lose weight from an acute illness, to put it back on can be very difficult. So I would go back 1 year ago and try and get as much detail as I can. Now, the other thing that I commonly see, I'm concentrating on some of the more subtle causes of weight loss, because I'm trying to be focused on the topic at hand, so we can discuss at length about somebody having weight loss, for example, with bloody diarrhea, which leads us to IBD. That's not what we are talking about here. Now, the other thing that I have seen is that the diabetic patient, either a newly diagnosed type 2 diabetic or chronic diabetic, but there's been some change in their medication. And if you look at it, a lot of these diabetic medications work through reducing appetite, and they just the funda is to make you eat less. It may be something like that. Maybe the metformin dose was increased. Maybe it was a newly diagnosed diabetic, or maybe they've got something like a voglibose, which induces malabsorption. So these are, that is one thing I found. And one interesting, not one, a few actually, a handful of interesting patients, elderly patients that I found is where they have dental work done to themselves. And the dentures don't fit particularly well. And they slowly, they would have had tooth extraction to get those dentures in. And so what was erstwhile a relatively stable situation now becomes, completely out of hand. They're edentulous. They have dentures that don't fit them very well, and they just go off their food. So you just have to, they may be hard of hearing, for example. So you just have to make that effort to get that fine detail. And then, the stress of the private world and stress of work. Somebody might have, it doesn't apply to this 56-year-old woman. Sorry, I'm slightly digressing, but you could easily say this is a 56 male who's lost 10 kgs. So they've increased, they're smoking more, they're kind of increased their alcohol consumption. They're not paying particular attention to what they're eating. And this depression that we've all talked about, but patients don't come and tell you that they're depressed, particularly in the Indian scenario. I've seen a lot of patients in the West who will sit across the table and tell you, doctor, I'm feeling low. Help me. But that is not a common scenario in India. You have to dig to find out about depression. So, for example, husband and wife, the husband might be, working in another town. Or, for example, I've seen a lady recently who lost her 84-year-old mother that she was really, really attached to. This lady herself was 50 years old. And then she just completely got withdrawn for the next 3 to 4 months. Her husband was really concerned, and he brought her to the OP saying that, the bereavement is not going as it should. So that was really obvious, but, if we probe deep enough, we might we might unearth some depression. And self-neglect in the elderly. So these are all some of the more subtle things that we would only find out if we actually spent some time getting a good history. Now, let us say I've done all this and I'm not getting any particular clues from all this. Now, I would obviously do the initial blood screen. I would definitely do it. A 10 kg weight loss, it's not something we can ignore. So that includes all the regulars, hemogram, liver function tests, and renal function tests, electrolytes. The specific ones would be serum calcium, which is like a paraneoplastic marker, and marker for metastasis, and TSH for weight loss, and fasting blood sugar for new onset diabetes, which the patient may or may not be aware of. And now I would certainly image this patient during the first consult. I think I would also say one more thing here, that I don't necessarily need to image in the first consult if I get some reassurance after doing all the thorough history and evaluation. For example, some patients, after you've spoken to them for 10 minutes, 15 minutes, 20 minutes, whatever it is, it actually helps them evaluate what has happened. So you have a couple of people, 2 people, 3 people across the table, they're all pitching in, and they may not have paid attention to certain small detail. And by the end of the consultation, actually you'll have the patient telling you, yes, doctor, it all happened after that little viral illness. Yes, doctor, it happened after the diabetic pill was changed. Yes, doctor, it happened after my anti-epileptic medication was changed. So by the end of the consult, if I and the family agree, actually I ask the family, once I think I have unearthed something that is subtle and is potentially contributing to the weight loss, I then ask the family, do you agree? I think it may be related to this. Yeah, and so at the end of the consult, if I feel confident, I would just do a basic screen and ask them to come back after 2 to 4 weeks. But if at the end of the consult, I feel I have not particularly, got any clues, and specifically, if the patients have lost muscle mass. Now, there's a difference between somebody coming and saying weight loss and then somebody actually having cachexia where they're losing muscle, or sometimes if you dig deep, they'll tell you that, they're not able to get up from the commode. One of the first things they tell you with cancer cachexia, proximal myopathy. So if the weight loss is like that and the pattern is that they've been losing weight more in the last few weeks or months, then in the first consult itself, I would image. That imaging would be a CT scan. If somebody has lost 20% of their body weight, I would scan the neck, chest, abdomen, and pelvis, literally the whole body, to make sure that I'm not missing a malignancy here. I'll stop there. I'm sorry, it's been a long monologue. So I'll ask Anoop to, tell me if there's anything else I need to elaborate on.
No, sir, I think what you were talking was quite relevant. In patients like these where history and physical is not leading us anywhere, one of the strategies that you emphasized is just taking more history. Even when history is not leading us anywhere, we just need to spend more time with the patient, maybe put our hands on other parts of the body and try and see if we can get some clue in terms of anything that we ourselves have been missing. And sometimes maybe the first 5 minutes of the interview does not pick up what the last 5 minutes of the interview does. So points well taken, sir. I have few questions which I have curated especially for you during this discussion. I will ask you those. And while I do so, I again remind any of the attendees, if you have any questions, comments, you can post it in the chat box, or you can raise your hand and I'll give you a chance to speak. So Sharat sir, is IBD ruled out historically if a patient has weight loss, but absolutely no lower GI symptoms like diarrhea, bloody stool, and whatnot?
It's a good question. Ulcerative colitis, you can almost certainly rule out because it is ulcerative colitis is limited to the colon. And more than 90% of the patients, the rectum is involved. So once your rectum is involved, inevitably you get symptoms. So I think you can fairly confidently rule out ulcerative colitis if somebody doesn't have diarrhea or bloody diarrhea, tenesmus. Now the slightly more difficult one is Crohn's disease, because Crohn's disease is a disease that can affect mouth to anus, and it's a split: 30% upper GI tract, 30% small bowel only, 30% colon only, and in 30% it is small bowel plus colon. That is the predilection for Crohn's in terms of location. Now, if you have small bowel only Crohn's, there is a possibility that your symptoms may not be very overt, as in no diarrhea, no blood in the stool. But again, more often than not, you will get some pointers there. You will get some abdominal pain, some postprandial discomfort, if not anything. There is some kind of a pointer there. So assuming that the patient is completely asymptomatic, abdominal examination is normal, patient is not anemic, and finally we have a test called fecal calprotectin. Fecal calprotectin is ultra sensitive for infection in the GI tract, inflammation in the GI tract. So if I have these and a normal fecal calprotectin, it rules out IBD.
So when we say completely asymptomatic, this patient did have upper GI distress, which to me sounded like dyspepsia. Of course, she had twice TMT done because we always worry about cardiac. Can dyspepsia be one of the signs, one of the symptoms of what you were mentioning about IBD, Crohn's disease?
Yeah, so Anoop, now dyspepsia again, it is still used even in published scientific literature, but it's a very loose term. It refers to upper abdominal pain, burning, bloating, nausea. it refers to a lot of things. Now, if the symptoms are limited to the upper abdomen, epigastrium, for example, and if they're consistently happening in the postprandial period after you've eaten, as in within half an hour after you eat, it is unlikely to be Crohn's. On the contrary, if you have pain which is more diffuse and in fact more centered around the periumbilical area, which is the area where small bowel pain is localized to, and the left iliac fossa or the right iliac fossa. Right iliac fossa is where your ileocecum is. Ileocecum is involved in 70% of the patients with Crohn's. So if you have pain, postprandial pain, which happens a couple of hours after you eat because the food has to reach that spot, then yes, that could be a pointer for Crohn's. On the contrary, if it is upper abdominal, epigastric, and it is happening more or less immediately after you've taken a meal, it is unlikely to be Crohn's.
Sharat sir, another question. In this age subset, new onset celiac disease, new onset tropical sprue, what is your thoughts on this?
Right. Yeah. So basically, celiac disease is non-tropical sprue. Previously, it was called non-tropical sprue. We don't use that word anymore. And now, a tropical sprue increasingly is it's incredibly rare. I've personally not seen a case of tropical sprue. There's a direct correlation with poverty, recurrent infections in children. It's not something that I've recently seen, so I would not be considering tropical sprue in this patient. Now, coming to celiac disease, yes, I've personally seen a lot of celiac disease in United Kingdom. Ireland is the capital of the world when it comes to celiac disease. 1 in 20 in the general population have celiac disease. So I used to see a lot of Irish patients when I worked in the north of England. So celiac disease causing weight loss only. And yes, at the end of history and physical examination, that would most certainly be on my differential diagnosis. But if you have celiac disease that is severe enough to cause weight loss, which usually would be because because there's malabsorption, fat malabsorption, I would have expected some steatorrhea to have happened, and the bloods to have shown anemia, CRP to have been raised. So in the absence, anemia is a very, very sensitive, not so much specific, but a very sensitive marker for celiac disease. So in the absence of anemia, steatorrhea, despite very severe weight loss, that makes celiac disease very unlikely. Now, would I still do a test for celiac disease? It is plus minus. If I'm clutching at straws, it's a very, very good screening test is anti-TTG antibody. It costs around 2,000 rupees and it has a sensitivity of 99%. So I guess there's no right or wrong way to do this, but yeah, if somebody wants to check it, it's absolutely justified.
And last question to you, sir, role of viral markers in this case.
Viral markers, I mean, if we talk about hepatitis B and hepatitis C, with hepatitis C has a higher propensity to cause.
Sharat sir, we lost you.
Yeah. So hepatitis C has a higher propensity to cause weight loss. Now, with a normal examination and a normal liver function tests, I don't expect either of these viruses to cause weight loss. Not hepatitis B, not hepatitis C. Now, whether HIV can cause weight loss in the absence, HIV and weight loss, that combination, as far as I'm aware, is you get weight loss if you've developed the AIDS defining illness, or, I mean, if you've had a serious opportunistic infection, or the HIV is preferentially afflicting the GI tract. For example, HIV enteropathy and HIV cholangiopathy, for example, and helminthic infections that complicate HIV. Those are the conditions that could cause weight loss in HIV, but I would definitely check. I would check for all the three viruses, not for anything else, but for the fact that if you combine Hep B and Hep C, the prevalence is close to 7 to 8% of the population.
Thank you so much, Sharat sir. At this point, I will ask Somaraju sir for his comment about today's case and the discussion that went so far. Somaraju sir.
Thank you.
Sir, sorry, yes, sir, please go ahead.
Thanks everybody, and learned a lot of things. One thing I must tell you, every patient I see is also seen by one of our physicians as a rule, particularly if a patient has this type of presentation. And most of my patients are also part and parcel of clinical evaluation by a physician. I won't refer to any other specialist first unless they are reviewed by the physician that I closely work with. That's number one. And number two, I must also, what Dr. Shankar was mentioning, gynecological evaluation doesn't need to be symptomatic. You can have significant gynecological illness and malignancy also at various sites without any symptoms and weight loss, etc. It should be done in the absence of symptoms in a patient like this, actually. That's one. And the other is, I wish to know more about this patient as a person, where she lives, who else lives with her, what is her family structure, and what are the issues, what is her food intake, a typical day, what does she eat, and her week, vegetarian, non-vegetarian, food habits, any change in food habits recently. All those things, some of them were already mentioned, but I would go in, typically I ask most of my patients, either me or one of my colleagues, tell me your typical day, typically the food you eat morning to night, and also your activity, your other issues, etc. Those details are extremely important. It's not enough to say we talk to patients, but what do you talk matters. Thank you.
Thank you so much, sir, for those comments. It is 8:02. Maybe we can be online for a minute or two more if anybody has got any other points to share before we close the session. Shankar sir, if I may ask you one question. What are the age-appropriate cancer screening that we routinely do in India? And I want you to be as pragmatic in your answer as possible, because trained in US, we had this so-called quality matrix. If we don't do this age-appropriate screening, we were not considered as a good doctor. Whether that's the right way to practice or not, I don't know. But we had a very strict criteria between gender specific and age specific. In India, will this patient qualify for any age specific cancer screening if she was to come in your OPD?
Definitely, the cancer screening, age appropriate cancer screening has to be done. Especially in the males, we definitely go for a prostate cancer screening. Where if there is a family history of prostate cancer is there, definitely we investigate further with the PSA, that is prostatic specific antigen. If it is more than 4, it is likely to be, it should be under surveillance. Then MRI of the prostate has to be done. If any lobe enlarged, then we have to go for biopsy. And so that if now robotic surgery has come, we can do radical prostatectomy. So the advantage of this prostatic cancer screening with the specific marker with the PSA, prostatic specific antigen. Then low colorectal cancer. There is a history of any adenomatous polyps. We have got one doctor family here. Most of their family members afflicted with the colorectal cancer. So adenomatous polyps, if they are detected regularly by the colonoscopy or a stool for occult blood, what I mentioned, advanced tests, so that we can investigate further with the endoscopy, colonoscopy, or sigmoidoscopy and biopsy, and we can act promptly. Then after prostatic and the colorectal cancer, then breast cancer screening, especially with the mammography, it is only 1,000 rupees test. We can find out so that mass in the breast. Then the cervical cancer screening with the pap smear regularly in females, and HPV testing, human papilloma virus testing. The lung cancer screening also, the CT test. These are the 5 cancer screening tests are supposed to be done in age-appropriate cancer screening. And if they are still inconclusive, then we have to go for a whole body CT imaging, as Dr. Praneeth alluded to. Dr. Sharath also alluded to. That is a thoracic, abdominal, and pelvic scan. Lastly, the PET CT also sometimes help.
Thank you, sir. 8:05. Praneeth, your closing comments for today's session.
Yeah, no. Firstly, a good case that we discussed. I think most of us do encounter these cases once in a while, and as a physicians, we all should know at least some basic nitty-gritties on how to approach these cases. And as discussed, from the non-organic causes to organic causes, a lot has been discussed in detail. And as Dr. Sharath and Dr. Somraju sir has highlighted, most of the time the history itself will kind of reveal what exactly is the reason for it. And the unfortunate part being the time that is not given to the patients because of the busy practice that we have, but that should not be the reason or excuse. For those deserving patients, I think that extra time needs to be catered, and if a thorough history and a detailed examination is done, most of the time we will be knowing what could be the reason, and when appropriate, the investigation in a methodical fashion, trying to look into from basic to detail or specific investigation will help us come to the diagnosis and evaluate this patient further. Those are my comments, Anoop.
Thank you, Praneeth. Thank you, all of you, for sparing your hour discussing this clinical topic with us. As you know, we do this weekly huddle discussion every week on Wednesday at 7 o'clock. The link that you used to join for today's discussion is the same link that works for the future as well. The ID and the password are static, so that same can be used. Previous episodes have been recorded, and a lot of them have been posted on YouTube and Castbox podcast, where you can spend your dead time listening to those. If you have any ideas about clinical topics that you think we should discuss in these kind of forums, please feel free to let me know, and I will try to find a clinical case that we may encounter, which we can put it in our future discussions. Thank you all. Special thanks to Sharath sir joining us for the first time. And I wish you all good night, and we will meet again next week.
Thank you. Bye-bye. Bye.